Okay, great. Thank you for inviting me to be part of this oral session. So children with pre- or perinatally acquired focal lesions have the remarkable ability to develop language within low normal or even normal levels. This is illustrated by a study by Bates et al. That directly compared children with congenitally acquired left hemisphere damage and adults with similar lesion types. And as you can see, in terms of number of errors made per mean language utterance, children actually make far fewer errors than adult counterparts. And when you then break down the adults with left hemisphere damage by aphasia subtype, as you can see here, the differences become even more pronounced. So there have been some functional imaging studies that have tried to look at some of the neural correlates of these very relatively good outcomes after early focal injury. But the majority of them have focused on localized changes. So they've either looked at activity around the area of the lesion or on the contralateral side to the lesion. But similar to adults, we know that early lesions are likely to cause damage remote from the injury site. And there's also some evidence that restitution of function might involve structural regeneration, not just around the area of the injury, but of the connections throughout the brain. So what we wanted to do in our current study is we wanted to move beyond localization, and we wanted to look at some markers of these language outcomes after early injury within the context of changes in the global functional network. Specifically, we did graph analysis, and we looked at the effects of early focal lesions on changes in terms of how central or important nodes are in the network. Node centrality has been shown to be a very powerful tool in terms of understanding neuropathology. A recent study by Crossley et al. Looked at 26 different neuropathologies and showed that what they have in common is that more central nodes are more likely to be implicated with the damage. And also specifically looking at adult stroke, a study looking at another measure of centrality efficiency identified that this measure is what predicts changes in terms of shifting towards local dynamics after stroke. So looking at centrality seems to be very informative in terms of understanding changes after injury. What we wanted to ask specifically is, do these relatively normal functional outcomes depend on whether central regions are spared from early focal injury? So if you look at a typically developing network in this little schematic here, and we look at a central node, if we have a lesion occur more in the periphery, we have a very clear prediction based on previous studies that we would expect that language outcomes would be better. Whereas we can ask if a lesion tends to occur more in a central or important node, then we would expect language outcomes to be worse. A second question that we were interested in is, how do these functional outcomes after early injury depend on the capacity of regions to organize or reorganize their centrality away from the typical network? So if we, again, take a little schematic of a typically developing network, we can look at central nodes and we can look at peripheral nodes and ask which are the ones that are actually changing in response to the injury, and how does this predict outcomes? So this is what we sought to do in our study. We looked at 24 patients that had pre- or perinatally acquired left hemisphere stroke. Their mean age at the time of the study was 14 years, and we also had 28 healthy age-matched sibling controls. And for all of the patients, we drew a mask in the lesioned area. And as you can see here, when we look at the overlap of the damage in the stroke patients, many key areas of language are affected in the left hemisphere. We use these lesion masks to then define what is occurring within the lesion and what is non-lesioned. So any voxel that was within the area, the lesion mask was considered lesion. Anything outside was considered non-lesioned, even though we know, of course, this is not the case. It's not fully spared, but this is kind of how we dichotomized the functional data. And then we had them undergo a category fluency task in a block design fashion. This has been known to just activate left lateralized language areas. And they basically had to covertly generate examples of categories such as animals. And then outside of the scanner, they underwent an overt measure of category fluency, as well as several neuropsychological assessments of language function. Because these were highly correlated, we collapsed these into a global score of their language ability after the injury. Then what we did is we took the task-related activity for the category fluency task, and we generated functional connectivity matrices from this, and we thresholded these across a range of costs, ranging from 0.5 to 0.3, which have been shown to be related to networks that have small world properties, meaning that they are dense but sparsely connected. What's important for here is that we require that all of the results be significant across the cost so that they were more reliable. And I'm only going to show you the results for one of the costs. And also we controlled for age as well as lesion size. So all of those effects were removed from our analyses. And just to give you a little bit of an intuition of the measures of centrality that we looked at, we calculated 3 complementary measures. One is degree, which is just how important the node is in the network in terms of how many connections it has. One is betweenness centrality, which just gives you an idea of how much of a transit point the node is, so how many of the paths pass through that node when you're looking at connections between other nodes. And finally, we looked at efficiency, which is just the ability of a node to propagate information throughout the network. And what we did is we averaged the control maps for each of these 3 centrality measures to get an idea of what the typical network would look like. So basically what we're doing is we're using these control maps to estimate the hypothetical uninjured properties in the patients. And we're doing that by looking at areas that are within the lesion and also the areas that are spared. So if you just look at these maps, you can see that we identify language-related areas as well as some of the areas in the midline that are known to be highly connected. So to our results, what we find is, first of all, in terms of the behavioral measures, so siblings did do better in terms of category fluency and overall language ability compared to patients, but the patients were still within normative values, so they were still on the low side of normal on these measures. And then we can ask the question, if more central regions are spared, are the outcomes better? So what we did is, again, we looked at regions that were spared, and we looked at the average typical centrality. And what we find is with betweenness centrality, the higher the betweenness centrality of the regions that are spared, the better the overall language functioning. So this suggests that if you retain regions that are normally important, the patients do better. Then we can ask the converse question, if central regions are lesioned, are the outcomes worse? And here we actually don't find any significant relationships between whether or not hubs or central regions are lesioned and any of the behavioral measures. So this really speaks to the plasticity of the early developing brain, because in adults it's been shown to be so important and such a common feature that more central nodes are the ones that are more damaged. Then we can go to our second question. What is the capacity of non-lesion nodes to change their role within the network or to reorganize? And so here I'm presenting an analysis that takes a little bit to unpack, but just bear with me. So what I'm showing here on the y-axis is the typical centrality of a set of nodes in one participant. So we can see that this is the value of centrality in the typically developing network. And on the x-axis, I look at the change in centrality in that patient away from the network. So I just take the difference between that patient's centrality measure and the control template. And you can see here that there's a negative relationship. So basically, nodes that are less typically central or less important are the ones that are reorganizing more and becoming more central after the injury in this patient. We can look at this relationship across all the participants, and we see that on average they all have this negative relationship. So on average, the patients take nodes that are not very central or important and reorganize them, and those are the ones that are changing the most, suggesting the nodes that have the most room to grow are the ones that are changing after injury. But there is a lot of individual variability, and you can see that some patients actually even have a positive relationship or don't have as strong of a negative relationship. And we can take the strength of this relationship and then we can relate it to behavior. And what we find is that, in fact, the patients that have this negative relationship are the ones that don't perform as well. So there's a positive relationship between the strength and category fluency. And if you just look at a patient that isn't doing as well, that's the one with the most negative relationship. So that's the patient that is taking nodes that are not typically central and reorganizing those. But if you look at a patient that has a mildly positive relationship, that's the one that's actually performing better on category fluency. So this is a patient that's taking nodes that are highly efficient in the typical network and making them more efficient. So just to summarize what I've shown you, we show that the higher the average typical between the centrality of regions that are spared from the injury, the better the overall language functioning, suggesting that retaining regions that serve as important transit points in the typical network are may be a mechanism for supporting better functioning after early injury. We also show a general tendency for patients to take nodes with low typical centrality and make them more central, suggesting that nodes with more room to grow are the ones that increase their centrality after early injury. But this doesn't necessarily relate to better outcomes, and instead, we find that patients that increase efficiency in already efficient nodes are the ones that have the most improved outcomes. So just to give you a general sense of what this means, our results corroborate previous studies that show that the so-called takeover of functions of regions that are not typically involved in language functioning might not be as beneficial for recovery after early injury. And instead, our results suggest that capitalizing on typical language architectures may be a mechanism underlying better function after early injury. And overall, measures of network centrality might be important markers for recovery and development after pre- and perinatal stroke. So I'd like to thank all of my collaborators involved in the study and all of the many institutions that were involved in this. And also thank you for your attention. And please come to poster 1442 if you have any questions.